I'm Dr. Sarah George. I'm one of the medical oncologists here at Florida Hospital East Orlando. I'm from Michigan originally, did my training at Wayne State University, went to Chicago for fellowship, and have been in Orlando since 2005 and have seen many wonderful changes happen here at Florida Hospital East since. So happy to be part of the Cancer Institute here since 2009. So today I'm going to talk about breast cancer, diagnosis and treatment, and there'll be some overlap in between all our slides, but just some reinforcement for you folks. So some of the signs and symptoms, as Dr. Constant Peter already eloquently spoke, include a breast lump that differs from the other breast. So I always encourage my patients when they feel something in their breast to feel the other breast as well to see if it's symmetric. Persistent swelling under the arms, skin changes, nipple changes. Some women have inverted nipples all of a sudden, and so if that happens on one side, that should be investigated as well, or nipple discharge that's unexplained. Dr. Constant Peter took a look at this as well, cross-section of the breast, and here you see the lobules that make the milk, the ducts that bring them up through the nipple. And this is the cross-section of one of those ducts. So we see how perfectly we have the lining of the cells on the outside and the inside of the duct as well. If you have a lobular carcinoma and it's in situ, meaning it stays within the duct, the lobule itself, we see that the cells have changed from the last slide that we just saw, right? The cells have changed in some ways, and we see that in here, when it becomes invasive, it spreads beyond the basement membrane, and it is a more aggressive type of cancer than it would be. This would be a stage 0. Here, if you have ductal carcinoma, compared to the first slide where we showed the duct, we see that the cells have changed as well. And here we see in ductal carcinoma, which has become invasive, the spreading of the cells beyond that basement membrane. So how do we stage breast cancer? When patients come to me, they always want to know, what stage am I? And that's a little more complicated than it sounds. So in addition to the type of breast cancer, we look to see how big is the breast cancer. For example, we talked about how it would be stage 0 if it's not passed beyond that basement membrane. We look to see, after we look at the size of the tumor, we look to see how many lymph nodes are involved, and then we look to see if it has spread beyond to distant sites of the body, far from the breast. And here we have a diagram too showing the stages of breast cancer as it spreads to the lymph nodes. Stage 4 is the most advanced form of breast cancer, where we see spread potentially to the lung, the liver, bones, and other organs, including the brain. So what are things to look for as far as breast cancer? What are things that are favorable if the pathologist looks at the biopsy specimen? Well, certainly the smaller the tumor, the better. The pathologists look at the grades of the tumor, meaning they look to see how aggressive is it under the microscope, and the lower the grade, the more favorable the outcomes as far as that goes. We talked about lobular and ductal carcinoma because those are some of the more common forms, but we also see that there are more favorable histologic types such as tubular and medullary. Patients also have reports on their breast biopsy specimens when they have cancer to say whether or not they're positive for female hormones, estrogen or progesterone, and those are actually favorable prognostic factors as well. And we look to see how rapidly the tumor is dividing, and the lower the S phase, the less aggressive the tumor. So we know that there are things in life we can change, and there are some things we can't change. We talked a little bit about the risk factors, and we'll go into a little more detail now. Some of our risk factors are inflexible. We can't choose our gender or our age, our family history, but some may be lifestyle related. So breast cancer is diagnosed 100 times more frequently in women than in men. But still, in 2014, it's projected that over 2,300 new cases of invasive breast cancer will be diagnosed. And of those, 430 men will die from breast cancer. We see that age plays a role too. As you get older, we have an exponentially increased diagnosis of breast cancer in women over the age of 55. Genetics, we always talk about family history, and that is very important. However, hereditary cases only comprise about 5 to 10% of breast cancers. We see mutations sometimes. Families have mutations of breast cancers where we'll see tumor suppressor genes such as BRCA1 and BRCA2. We'll see tumor syndromes where you have gene mutations that predispose you to other kind of cancers, such as skin tumors, gastric cancers, and other tumors as well. So BRCA1 and BRCA2 have been well publicized after Angelina Jolie, but they should be suspected in premenopausal young women who have this diagnosis. We see it more commonly in the Ashkenazi Jew population, and often multiple family members are affected. Genetic testing is recommended, especially if there's a male breast cancer. And we see the astronomical increase by age in the risk of developing breast cancer in patients who have the mutation for BRCA1, as well as other cancers, which we don't hear as much about. In BRCA2 mutations, there's also a risk of other malignancies, including GI, melanoma, and even early onset prostate cancers. So when do we do genetic testing? Well, if we know that a family member has a known family mutation, if you're of the right racial makeup, the Ashkenazi Jews, and you have a personal history, males, certain GYN malignancies, or if you are very young with a personal history of breast cancer, or if you're less than or equal to 50 and you have high-risk situations, they recommend it, or if you have multiple primaries as well. So 85% of women with breast cancers don't have a family member involved, but if you do have one relative versus two relatives, you see your increased risk of developing the malignancy. Having your own history of breast cancer actually increases your risk of having breast cancer in the future. If you've had a history of invasive breast cancer, you have a 3 to 4 time increased risk of developing cancer in the same or the other breast. If you have precancerous conditions as well, even if this precancerous condition we talked about, the lobular carcinoma in situ, which is not considered a cancer as of yet, but it does convey a much increased risk. Menstrual history, Dr. Constant Peter talked about. The longer the period of uninterrupted progestin, the higher your risk of breast cancer. So early onset menstruation, late onset menopause, your first child after the age of 30, but you can decrease your risk by prolonging breastfeeding, actually. Hormone replacement therapy in the estrogen and progesterone family have been found to decrease the effectiveness of mammograms by increasing breast density, although that does return to the risk of the general population after discontinuing the medication. Alcohol use, believe it or not, can increase your risk of breast cancer. 2 to 5 drinks per day can increase the risk of breast cancer 1.5 times more than in the non-drinking population. Obesity can increase insulin levels and also increase estrogen production. Actually, a weight gain of 21 to 30 pounds after the age of 18 conveys a 40% increase in the breast cancer risk. So how do we treat breast cancer? Well, Dr. Chu is going to talk to you a little bit more about surgical options. I'm going to touch briefly on chemotherapy, radiation therapy, and endocrine therapy today. So I'll leave this up to Dr. Chu to take over. Lumpectomy, mastectomy, the lymph node assessment like we talked about for staging. But as from my perspective, I'll talk more about the chemotherapy. So when do we give chemotherapy? Not everybody with breast cancer needs chemotherapy. We use chemotherapy sometimes if there's a larger lesion to shrink the lesion. Sometimes we'll use it after surgery if the patient has high-risk disease or node-positive disease, meaning if the lymph nodes are positive. If the patient has widespread disease, we'll use it as well. Radiation therapy can be used. Now, how does chemotherapy and radiation therapy differ? Chemotherapy are drugs given either by mouth or by IV that go throughout the body that kill off some of these tumor cells. Radiation's kind of like a laser beam. It hones in on a certain area of the body. We use it if patients had a lumpectomy to sterilize the breast, or if the margins after the surgery has been done are positive, meaning if we see that there are tumor cells at the edges of what has been resected, if the lymph nodes are positive, or if a patient has spread of disease to their bone and they're having pain at those sites. What is endocrine therapy then? Well, that's kind of an anti-tumor effect. Tamoxifen has been used, and we've probably all heard about that, in patients who have in situ carcinomas or in premenopausal women, because it does restrict ovarian function of estrogen as well and block that. In postmenopausal women, or in patients who have, in postmenopausal women and patients who have widespread disease, we can also use nonsteroidal and aromatase inhibitors and other medications to control the estrogen flow of the body if the patient, again, is positive for estrogen. So this is used as a blockade term. We have other forms of targeted therapy. There's another thing called HER2/neu that I didn't talk about. HER2/neu is actually a protein that's overexpressed on the surface of some breast tumor cells. And we have targeted treatments for those that are good. Some newer ones are coming out every day. Risk reduction strategies. We also, some women don't have a history personally of breast cancer, but they may have precancerous conditions. They may have had multiple breast biopsies. Go to your doctor. There's something called a Gale model where they can figure out what is your risk of developing breast cancer over the course of the next 5 years. If you're at high risk, then they may choose to put you, if you're premenopausal, on tamoxifen, or postmenopausal on raloxifene, which are some of the treatments we have available to us. If you are a carrier of one of the gene mutations that we spoke about, sometimes mastectomies, as Angelina Jolie did, or abdominal hysterectomies are recommended depending on the mutation itself. Thank you.